This podcast is brought to you by ProLongevity, the award-winning 8-week program that can transform the lives of people with prediabetes, type 2 diabetes, and many other lifestyle-related illnesses. Founded by Graham Phillips, the pharmacist who gave up drugs.
Hello and welcome to the latest edition of the ProLongevity Podcast. Now, today is number 3 in a series. If you've been following me, you'll know that I've become absolutely fascinated by the relationship between what we eat and our mood and how we feel. And, you know, for years, I've noticed that when my clients' metabolic health improved, their weight went down, their waist got smaller, their blood pressure got smaller, so many of them said to me, I just feel generally better. And I thought, well, that's great, but I never really understood it. And I'm not saying I thoroughly understand it now, but that's why I have experts like Georgia with me. But if this is an area of your interest, please do go back and look at my first podcast where I interviewed Brett Scher on the subject. And a more recent one I've released with Erin Bellamy. So I think we're building the case here. And today is the crescendo with the wonderful Georgia Ede, who I've spent some time with, got to know, and has just published a wonderful book. So called Change Your Diet, Change Your Mind. Georgia, absolutely great to have you with us.
Thank you very much for having me and for your interest in this really important topic. I really appreciate it.
Yeah. Well, as I've said on previous podcasts, I'm very grateful myself because my mental health has never really been too much of a problem. But my father's, both my parents are still alive, very frail, but still alive. And my father was bipolar. And before there were many drugs around. So, you know, he, nothing worked for him and he had years of misery. In the end, the only thing that worked for him was electro ECT. Which isn't used very much. I think it's kind of fallen into disrepute, but actually for some people it's remarkably effective. For him, it changed his life. And my mum's depressive. So I know what it's like to be brought up in a household where there's depression around. And obviously, as a pharmacist, we come across mental health issues all the time, but I'm really passionate about this. And, you know, leaders like you, Chris Palmer and so on, and what the Bazookies are doing is fantastic. So hopefully we'll explore a little bit of that. Now, Georgia and I have had a prior discussion and we've prepared a few slides because we think it'll help guide the conversation. And we don't want it to be a slideshow, but we want it to be the basis of a conversation. So I'm just going to share the screen, Georgia. Just let me make sure I've got this good to go. And one of the things that strikes me, if you've never had poor mental health, you really don't know what it's like to suffer. And I've seen this in my own family where a family member will suffer and someone, you know, other members of the family say, what's the problem? Just pull yourself together. So if you've never known poor mental health, it's very hard to understand what it means. And it occurred to me equally, if you've only ever known poor mental health, it's very hard to even imagine what life must be like without it. So obviously we don't want to go too deep into the weeds, but I thought you might just generally, the other thing is, it's very hard to really understand a diagnosis, I think, with mental health. You know, in the case of blood pressure, you've got an absolute measure of systolic and diastolic. You can watch the heart in motion. You can have absolute numbers. You can administer antihypertensives if that's the way that you want to go. And there are numbers to prove it. Doing that in the area of mental health, I think, is much less scientific. And you may disagree with me. And I think about mental health, these kind of descriptions are more syndromes than absolutes. But what's your take on and these are just a random selection of common conditions. What's your feeling on this, Georgia?
Well, in the book, I make the point that psychiatrists, you know, there are many different types of mental health practitioners, and psychiatrists are the mental health practitioners who have medical training. You know, so we go to medical school and we can prescribe medications, and we're supposed to know more about the biology of these conditions than even the psychology of these conditions. We're trained in both, but we are supposed to be the ones who are capable of understanding the biology of these conditions and treating them with biological interventions such as medications. And yet the biology of these conditions is really the piece we understand the least. And so diagnosing, as you rightly said, diagnosing these conditions is really very much, it's not a very scientific process, I guess we'll put it that way. These are more syndromes than anything else. We don't have biomarkers for these conditions. It's not as though I can do a blood test and tell you definitively whether or not you have, say, schizoaffective disorder versus schizophrenia versus bipolar disorder. And there's a lot of overlap between these conditions. And in truth, there's a lot of overlap between all of these conditions. Just about any mental health condition you have, and many people have mental health conditions now. If you don't have a mental health issue yourself, then somebody you love does. I mean, none of us is untouched by this. So I think, what if you have a mental health condition of any kind, you're going to have more difficulty paying attention. You're going to have some symptoms of ADHD. If you have depression, you're also going to have some symptoms of anxiety, and vice versa. And I think this is where I think we have become. I think psychiatrists sometimes are viewed as less medical, sort of less, in terms, because we don't have these rigorous ways of diagnosing and treating mental health conditions. In fact, even now in 2024, the practice of prescribing medication is really a trial and error process. And it's very frustrating, and it can take, in some cases, a year or two to find a medicine or combination of medicines that is worth taking, and because it brings enough benefit. And of course, in many cases, we don't find that medications bring a lot of benefit. So it really is, we've been practicing in the dark for a long time. And so this is one of the things I point out in the book, is that we come to this problem honestly. I mean, the brain is very difficult to study. And, it has a separate circulation, and I can't draw your blood from your arm and tell you what's going on in your brain because of the blood-brain barrier. And so I can't tell you with any certainty what quote unquote chemical imbalances you may have in your brain. And yet I am taught to prescribe somewhat randomly a series of medications to try to address those assumed chemical imbalances. And so I think that, it's really, really time for us to be stepping back from trying to understand the brain and all of its complexity, and reminding ourselves that the brain is part of the body. And we can learn so much about brain health if we think about total health and metabolic health.
Yeah, I couldn't agree with you more. And that phrase that you originated about the brain being part of the body, I mean, it's obvious, isn't it? But it's really made a lot of us think, because all of us as practitioners, kind of the brain is separate. It's almost like the brain is completely disconnected.
Yes.
It's hard to describe, but can you give a sense of what it's like to live your life with a severe mental health condition? How do people feel? How is life for them? I've got a client currently, and it's fascinated me. I gave him the confidence to try the keto diet, despite the increase in LDL. And it was 3 weeks had gone by, and we met, and he said, "I cannot believe it. I've never felt like this." He said to me, "I've lived my entire life in black and white. I had no idea that life could be full color, full on like this. And I never expected a result like that. I make no promises, Sometimes you just hit the sweet spot and it works." And it just occurred to me, he'd never really experienced life as it could be. And 3 weeks on, a revolution now. Whether that will last and whether that's job done is a whole other debate. But the fact that he's been able to experience that, and it's revolutionized his understanding of what life can be.
Exactly. And this is not an uncommon experience. So for those of us, the small but growing number of us who are using ketogenic diets and other really targeted nutrition interventions in our work, but particularly ketogenic diets. Around week 3 is when you see a shift. Most people will make this shift by week 3. Sometimes it may take 6 to 12 weeks, but in many people, you see it at week 3. There's something magical about that time frame. A profound change in state of mind. And it's often a state of mind that the person you're working with has never experienced before. And it's usually a noticeable enough experience and a positive enough experience to help keep the person motivated to continue eating in a different way, because as we know, eating in a different way can be difficult. So I think this is an experience. The whole reason I wrote the book is this is an experience that people with mental health conditions deserve to explore. And if you haven't tried these interventions, you do not know yet what is possible for yourself, because it can be, and I know this sounds dramatic, but it's absolutely true. It can be life-changing. And, who doesn't have 6 weeks or 12 weeks at the outset, at the most, to invest in their own mental health as a sort of curiosity and discovery experiment? You're worth it.
So that's interesting. So this 3 weeks, which I just thought was serendipity, in your clinical experience, that's a common time frame for some kind of switch to go on and a big change. Oh, that's my number one learning from today. I just thought it was a one-off. You've convinced me it's a bit more than that. So yeah, I love doing these podcasts, not least because I learn so much. Okay, this is just really a reflection on. In prep for the podcast, we're all aware that mental health has suffered, and the whole coronavirus, the isolation, and all the changes, the social isolation, babies being brought up, so only seeing adults with masks, all of us interacting in 2 dimensions instead of 3. Etc. etc. So you may not know Mind, the big mental health charity in the UK, but it just struck me how much an impact. So coronavirus affected all of us, but I think coronavirus affected people with poor mental health, who were already doing the worst, who already had the least support, who were already the most vulnerable, even more so. So the key points, this was a big study that they published in July 21. People who struggled before now struggle more, increase in anxiety. And of course, we talk about health inequality a lot. I don't know whether it's as big a thing in the American system, but it's a major focus in UK healthcare, which is something called the inverse care law. Those who need the most care get the least. And I think that's generally true. And it's more specifically true in mental health. So you've got sort of double health inequality. There was already a crisis in mental health in young people, and I'm sure we'll talk about that. So all these things I think have got worse over time. And in prep for a talk I gave recently, I was just having a look at my professional journal, the pharmaceutical journal. And GPs are already being condemned for doing either too little or too much. So on the one hand, antidepressant prescribing is increased by 35% in 6 years. And even more strikingly, the number of young children prescribed antidepressants has risen by 41%. So our GPs, our family doctors, and as you know, my partner's a GP, get opprobrium heaped on them for over-prescribing, but equally they get the same amount of opprobrium heaped on them for not doing enough for mental health. So I just wonder what your experience has been through the whole coronavirus and this escalation of poor mental health and escalating prescribing.
It really reflects the fact that we do not understand what causes depression and anxiety. And so the only thing most people know how to do is write a prescription. And these, as I'm sure you are well aware, these medications fail most people. They do help some people, I've been prescribing medications. I continue to prescribe medications as part of my practice. It's not the primary goal of my work, but of course I still use them. And, there's a place for them. But having prescribed medications for 25 years to thousands of people, I can tell you that they do not work for most people. And they may bring some relief, they may bring temporary relief, but even the people who do best on medications, in most cases, they are paying a price for that relief in terms of side effects. Sometimes, minor side effects in terms of quality of life. Maybe they can't experience the same degree of joy that they could before. There's a little bit of apathy, a little bit of flattening of their emotions. Maybe there are sexual side effects. That's a significant quality of life, impairment. But in worse than that, worse than both of those things, which are already no fun, we have a real negative impact on the length, duration of life, and on metabolic health. So many of these medications, especially the stronger medications, such as antipsychotic medications, which are now prescribed not just for psychotic conditions, but also for depression and anxiety and even insomnia. Yeah. And so mild mood swings. And so they're prescribed for all manner of things. And these take a tremendous toll on metabolic health. They can raise blood sugar and insulin levels within minutes to hours of the very first dose. And there's a very high incidence of type 2 diabetes, obesity, high triglycerides, and these medicines, and cardiovascular disease, these medicines shorten life. And some of my patients have gained 100 pounds or more on antipsychotic medications, and that is the price that some people are willing to pay because they need to be able to function. Yeah. They need that relief. But what if there were another way? And I think, or that would help you need less medication, or perhaps even completely eliminate your need for medication in some cases. So why not explore those possibilities? Because the options we have right now are really far from ideal.
Yeah, I mean, people naively assume that medicines are either safe or unsafe, and they either work or they don't. And all of us as health professionals know it's far more complex than that. The definition of an effective medicine, the technical definition, is the one that benefits 35% of people. That's an effective medication. That's probably your antihypertensive medication, right? I don't know I don't know the answer to this. I don't know if you do, Georgia, but generally the first or second medicines that you try in a given, and it will vary by condition, how effective do you think they are if you had to sort of give it a vague rating in terms of efficacy?
Well, I do have some, statistics from studies, and then I have my own clinical experience. So, in terms of the antipsychotics, which are the most powerful, most effective medications we have available to us, it's really, less than a third of people will be helped by those medications. So I think that, and we are talking about, if we're talking about the antidepressants, the numbers are far smaller. So depending on which study you look at, it could be as little as 2% of people benefit from these medications, up to maybe 10%. And the degree of improvement, is very small. So we're not, most psychiatrists' practices gradually fill up with patients who are not getting better. And then our role becomes support, refills, encouragement, and finally, starting, 10, 15 years ago, I had another approach where I could actually, if I, thought I'd run out of ideas, now I have a brand new idea that I can suggest to people that, that I think is really hopeful. And so I can instill hope without promising. I can instill hope, based on biology, based on very, very strong science about how metabolism works, how the brain works, and how, for example, ketogenic diets can stabilize brain chemistry. And so, and not with, side effects are very uncommon and temporary. Instead of that, we get side benefits
100%.
for total health, not just brain health, but total health. And that's wonderful to be able to have that option available to people.
So we all have our own personal health journey, right? My health journey was I was a fat kid who became a fat and hungry adult. And it was only when I started to explore, and I thought I knew the science, right? Calories in, calories out, eat less, move more, and all of that. And I could starve myself for a bit, lose the weight, and it all came back on. And it's only as I started to bump into David Unwin and the keto community that I learned a completely different approach. And it has changed my life. I talk about the tyranny of food. Because I used to be like, I'd be desperate for breakfast. And when I finished my breakfast, it was almost like I was hungrier than when I started breakfast. Yeah. And I'd spend the whole morning looking forward to my lunch. And at the end of lunch, it was almost, it only partly slaked my hunger. So my whole day was dominated by the next meal. And yet when the next meal came, unless I ate ludicrous quantities, it never really satisfied me. And now I'm, if I go 24 hours without food, it's not a problem. I can pick and choose. What's your journey been? Because, I mean, I was conventionally trained. I think you were conventionally trained, and we both ended up in this slightly wacky place. How did you end up here?
So I think most of us who end up in this newer place, approaching things from a different point of view, come to these realizations through our own health journeys, right? And so we become very motivated because we've discovered something that helps us that we think may help our patients, and that's exactly what happened to me. So I also, I come from a family where just about everybody has a weight problem. Grew up, even when I was, first or second grade, I was already overweight compared to my peers. And that in and of itself is a very, very uncomfortable psychological experience for a kid.
Particularly for a girl. Yeah.
Particularly for a girl, but for a boy too.
Yeah.
I mean, especially back then in the 70s when, most kids, were not overweight. And now I look around and I see most kids are actually overweight. And that's what in the world is happening. So growing up overweight, always on a different diet, right? So low calorie diets, low fat diets, exercise, Weight Watchers, cottage cheese diets, grapefruit diets, cabbage soup diets. I mean, I tried them all, and so did my mother, and so did my sister. So this was, we were always on a diet in my house, and up and down, weight going up and down, always feeling hungry, always being frustrated, and feeling, okay, well, why do I have to do this when I look around and all my friends are sort of just eating whatever they want and maintaining a normal weight? That's always been fascinating to me. Mm-hmm. But then, so that's a long time ago. So I've tried different diets. Eventually I stumbled on the South Beach diet, which had something to do with the glycemic index. That seemed to work a little better. In my 30s, that seemed to help a little bit better. And then I stumbled on the Atkins diet in the 90s. She lost 90 pounds on the Atkins diet.
Wow.
And that got my attention. And so I became interested in low carbohydrate diets. And, but then, some years went by before I ever discovered ketogenic diets, which are really very different, from Atkins diets in a lot of ways. So what I discovered for myself had actually nothing to do with weight. It was that I had developed some health problems in my early 40s that a lot of my patients were also struggling with. And, these are things like fibromyalgia and chronic fatigue and IBS and migraines and things like that, just not feeling right. And all my tests were normal, went to lots of different specialists, and just started experimenting with my diet to try to deal with the IBS piece, at least, right? Because I thought, well, at least that's stomach related. Maybe that's something I'm eating is bothering me, and maybe I can at least deal with the IBS. long story short, 6 months of trial and error, changes to my diet, every symptom I had of every condition I was coming down with disappeared.
Yeah.
And this was this upside down diet from what we're told to eat. So, and combining those principles with a ketogenic diet was really life changing for me, and got me really, really interested in nutrition. So that's when I first started studying nutrition. As you know, at least in the United States anyway, medical doctors are not taught about nutrition.
They're not taught here either.
Okay, so there you go.
I gave a talk recently to a GP practice, and they had 2 GP trainees, family doctor trainees. One of them had basically done no nutrition. The other one had done, I think, 1 day. And the whole 1 day was, a little about vitamins and a little bit about calories. So none of us have any training in nutrition or exercise or sleep, which I think are the fundamentals.
You're absolutely right. 4 years of medical school, I think we had 2 or 3 hours, a lecture, 2 or 3 hours on nutrition, nothing but brain health and food.
Yeah.
And 4 years of psychiatry residency, we didn't talk about food once. So I never really made that connection for myself until I noticed when I changed my diet. I wasn't trying to improve my mental health. I never thought of myself as having any major mental health issues. I mean, I got winter depression, which I thought was normal. I become anxious on Sunday evenings before Monday morning work. I thought that was normal. I'd be pretty wiped out by the end of the day in terms of mental stamina. I had really nothing left. I'd get easily overwhelmed if there was a lot to do. I thought all of that was normal. But when I changed my diet for my physical health, my mental health improved, concentration, mood, energy, mental stamina, everything got better. I thought, this diet seems to be good for the brain. I need to learn more about this.
Absolutely. I mean, I just reflecting on my origins. When I was at school, I was the fat kid in the class of slim kids. And I tell you what, I was never very athletic as a kid, and I was quite embarrassed about that. And I remember they used to pick the football teams. So they'd pick 2 captains, and then you'd probably call it soccer. And the captains would pick the team. I was always the last to be picked. And I always I always ended up in goal. Maybe I was so big that I actually blocked the goal mouth. I don't know. And it didn't. I mean, I've come to terms with it, but at the time it was painful, and yet probably most kids feel like that now.
Okay.
Not good. Okay.
No, not good. It's a humiliating experience to be metabolically unhealthy as a kid, and you get teased. You're not picked for for sports teams. It's humiliating, and it takes a big toll on your psychological health and your self-esteem.
So I think we've kind of begun to really talk about maybe the cause is something around metabolism and diet, and the role of insulin and the rest of it. So perhaps talk to us a little bit about insulin resistance. It's a pandemic. I agree with you. And I think maybe the data is, I looked at this and I thought 52% of Americans, that's the minimum. And we in the UK, I'm not sure we're as far behind the rest of our American friends as that, but where does this data come from? What does it tell us?
Yeah, so what's interesting about the numbers is that they're very likely, at least outside the United States, these numbers are likely underestimates, and that's because of the way it really depends on how you measure it, how you define insulin resistance. So if you're really using good measures of insulin resistance, accurate measures of insulin resistance, then you will find, I think the numbers will be much higher.
Yeah.
So in the United States, the reason I have these numbers, the reason they look much higher is in part because other countries are not quite as advanced in terms of their metabolic deterioration as we are, but also because the studies are using weaker measures of insulin resistance.
So, I mean, I think you and I talk about insulin resistance on a daily basis, but I think for the lay audience, that's quite a technical term. So I'm going to give my description, and you'll probably have a different description. The way I explain it is this, that at any one time, the entire bloodstream, 8 pints of blood, should have basically one sugar lump in it. And if you've got 2 sugar lumps in your entire bloodstream, you've got type 2 diabetes. And if you've got 3 sugar lumps in your bloodstream, you're basically dead. And this is the principle of homeostasis, the very tight control of the entire internal environment. And insulin is a fascinating hormone. So much so that every single cell in the body has an insulin receptor, which gives you an idea just how profound the influence of insulin is. And we think about insulin as the way, as a prime function. It removes the excess blood from the bloodstream, which it does, because excess blood is toxic. But if you've got a diet where you're continually putting more and more sugar and carbs into your system, into your body, you're forcing up your insulin all the time to try and drag the blood glucose back to normal. More and more insulin, more and more sugar, more and more insulin, more and more sugar, you're on your way to metabolic syndrome and insulin resistance and all the rest of it. And there's a sort of a well-known phrase that the dose makes the poison. And I think that's true of insulin too. Not that insulin's poisonous, but as your body secretes more and more insulin in a forlorn attempt to control your blood glucose, and you're forcing all this excess sugar, first of all, into your liver, and then you're forcing, the liver then makes fat from it, and you're then forcing all of the excess fat into your cells, and your fat cells become stuffed full with fat and start to groan and become insulin resistant because they've got nowhere to stuff the insulin. So you're living your life with permanently raised insulin as a result of your diet. And as a result of your raised insulin, the cells stop responding in the way that they normally do. And that all sounds quite straightforward until you realize that insulin has multiple actions on multiple cells. And also that your cells don't become equally insulin resistant at the same time in the same way. So some cells might become insulin resistant, but other cells will continue to respond to the higher levels of insulin and go into overdrive. So that's kind of my take on insulin resistance in a teacup. Do you agree with that? Have you got a different perspective? Is that a fair summary?
Yes. So, if you eat too many of the wrong carbohydrates too often, you will overwhelm your bloodstream with too many glucose molecules, which will then require too many insulin molecules to mop them up. And high insulin levels, if you're living a high insulin lifestyle, as I like to say, that's very dangerous for every cell, every organ in your body. Because as you said, every cell has an insulin receptor, and the higher the insulin levels are, the more resistant most of your cells will gradually become to insulin. It's a totally normal and natural reaction to an excess level of a hormone. Is again, the body's trying to restore equilibrium. These cells don't want to be overstimulated by insulin, so they pull back. And so you need more and more insulin to try to get the cell's attention. And eventually what happens is the brain becomes insulin resistant, and it becomes more and more difficult for insulin to cross into the brain where it is needed to turn glucose into energy. So paradoxically, the more sugary your diet is, the harder it is for your brain to use that sugar for energy. And so insulin resistance is the natural result, the perfectly predictable result of overwhelming your bloodstream with too many glucose molecules. And every cell is listening, including every cell in the brain. It's like, and it's not just, as you were saying, it's not just a blood sugar regulator. Insulin is a master growth hormone. And so that's why all the cells are listening. The cells are listening, what are we supposed to do with this energy that's coming in? Do we need to store it? Do we need to burn it? Do we need to build something out of it? What do we need to do with it?
Yeah.
And insulin is it's like the conductor. I wrote this in the book. It's like the conductor of an orchestra. And all of the cells are the musicians in that orchestra, and they're listening They're paying attention as insulin goes up and down. Your stress hormone levels are going up and down. Your reproductive hormones are going up and down. Your appetite hormones are going up and down. Your blood sugar regulating hormones are going up and down. You're on this invisible internal hormonal roller coaster all day long and well into the night. This is very destabilizing for people. And most people have no idea what it's like, what it feels like to step off of that roller coaster.
You and I do.
Yes,
and it's
we
been
do.
a revolution, right?
We do. Yes, it feels wonderful.
I want to talk briefly about epilepsy and the ketogenic diet. For reasons that will become, and for a lot of people say, well, what's this got to do with mental health? But there is a link. So briefly, we know that fasting and dietary regimes have been used to treat epilepsy since biblical times. Remember, there weren't a lot of drugs around in thousands of years ago. And I think it was Johns Hopkins University. They used to treat particularly epileptic children by fasting. And obviously it works. Even now, status epilepticus is a very severe form of epilepsy. And in specialist epilepsy centres, it's still used today as a treatment for very drug-resistant epilepsy. But you can't starve a human being forever, and you certainly can't starve a child for a long period of time without doing other sorts of damage. And so the ketogenic diet, I think, was introduced, first in Johns Hopkins University, as a way of essentially mimicking the effect of fasting. And it was used, as I say, at that time to treat intractable epilepsy. And everything was known about it until the drugs came along and kind of supplanted the keto diet because, well, all sorts of reasons. Some have got to do, I think, with the perceived difficulty of staying on the diet, but also I think a lot of it's got to do with the way we as health professionals are trained, and also the drug industry. Because, you know, if you're using a diet to treat your mental health condition or your epilepsy, you're not going to be using many drugs, and that's not to the benefit of the industry. So I think it kind of got forgotten about. I think the next part of the jigsaw, certainly for me, and as you said earlier on, quite a lot of anticonvulsants, anti-epileptic drugs aren't just used to treat epilepsy. They're also used as mood stabilizers in schizophrenia, bipolar, etc. So lithium is the same. So there's this kind of mix of diet and something around the brain because of epilepsy. The drugs that we use to treat epilepsy, we're also using in other mental health conditions. So the whole thing, it's all a bit crazy mixed up, but it's very hard. You know, you can go back thousands of years and say, well, thousands of years ago, we knew that diet affects epilepsy. And hundreds of years ago, in the last 100 years, we've certainly used anti-epileptic drugs to treat moods, for example, some of these that are up on the screen.
It was a beautifully described history of the ketogenic diet, which so many people still think of as a weight loss diet. I mean, the ketogenic diet certainly can help you lose excess body fat, but it was originally designed in 1921 to stabilize brain chemistry. It's designed as a brain stabilizing diet. So, we've got now more than a dozen randomized controlled trials documenting that in people with epilepsy, children and adults, in people with epilepsy, more than 50% of patients experience more than a 50% reduction in seizure activity and more than 10% completely seizure-free. So if that's not stabilizing brain chemistry, I don't know what is, right? And as you said, we psychiatrists, we prescribe anticonvulsant medications like lamotrigine and valproate and topiramate for bipolar disorder all the time. And they're actually bipolar disorder and epilepsy have very, very similar biochemical underpinnings. They have a lot in common. I often will refer to bipolar disorder as emotional epilepsy. And So it's these unpredictable shifts in brain energy that will cause emotional symptoms as opposed to motor symptoms and muscle symptoms, right? And so if this diet, which has been so effective for epilepsy, if it can be that effective, couldn't it also be effective for bipolar disorder? And that is the brilliant work that's going on around the world now, especially right there in the UK at the University of Edinburgh. Dr. Ian Campbell is publishing some really wonderful data on studying, looking at the effects of ketogenic diets in people with bipolar disorder. He himself has put his own bipolar disorder into remission now for 7 years on a ketogenic diet. So this is a very, very powerful metabolic intervention for potentially for bipolar disorder, as well as perhaps many other brain conditions as well.
No, absolutely. And as you were talking, I was just reflecting on an experience I had recently. So there are all sorts of specialist groups within pharmacy, including a specialist group who are specialists around the area of epilepsy. And so I attended one of their lectures recently. And it was all about the drugs, only about the drugs, and nothing except the drugs. The old drugs, the new drugs, drug development, drug pathways. And I was kind of screaming at this, raving at this. Someone's going to talk about diet at some point, right? No, nothing. And credit to them, at the end, they got expert patient representative. And she was an amazing communicator and talked about her experience as an epileptic. Imagine what it must be like to experience an epileptic seizure during sex, which is something she talks about. How does your partner feel? How does that make you feel? I mean, that's how dreadful it can be. So anyway, there was a chat. So I put into the chat, have you ever thought about the keto diet? And she responded to say, no, that's just something for kids. That's not appropriate. So I just put in, could we have a chat offline about this? And she said, sure. So a couple of days later, we had a couple of hours on the phone. We went through all of this stuff. And I'm hoping, because she's an influencer, that we can convince her to have, and obviously, let's be very clear. I think this is a really important point to make. We are not saying that this is a miracle cure for everyone. And we are certainly not saying just have a keto diet and stop all your drugs. We are absolutely not saying that, right? So let's be very, very clear about that. But if one can introduce the diet within a safe area, working with your health professional team, then it may be possible. So I'm very clear that we don't want to overclaim or lead to someone coming off drugs when they need them with potentially catastrophic circumstances. But that just really struck me. Anyway, when she described her epilepsy, she also described a number of other mental health conditions. So it was just interesting to see the link that she doesn't just have the epilepsy. She described, I think, bipolar and a couple of other anxiety and other issues. So even in one human being, one can see that these things all come together in a group. But she would probably be branded just as an epileptic.
Well, that may be the most dramatic, of the types of symptoms she has, because an epileptic seizure is a very noticeable, very dramatic black and white event.
Yeah.
But of course, she has other mental health problems. So the brain is not divided into these neat boxes where you've got an epilepsy box and that's not doing well, but all the rest of the boxes are left untouched, right? Yeah. So it's an organ and it's intricately connected. All the areas are intricately connected. And so if the brain isn't functioning properly, the brain isn't functioning properly, emotionally or physically or in any other way. So this is, and I do want to sort of reemphasize the point you're making about medications. And so anybody listening to this who's thinking about trying a ketogenic diet for mental health reason or any other reason for that matter, especially if you're taking medications or have a history of high-risk symptoms, it's really, really important for you to work with a professional to help monitor your symptoms and especially your medications while you're transitioning onto the diet. And you had flashed up a few minutes ago, Graham, on the screen, this image about my clinician training program. The reason I created that clinician training program for ketogenic diets and mental health was to make sure that practitioners knew how to safely guide patients on medications and with different health issues and with different mental health concerns, safely guide them through the transition phase onto a ketogenic diet when these are very powerful interventions. And that's what you want. You want a powerful intervention, but it can have a profound effect on your medication levels, your fluid and electrolyte balance, your blood sugar, your blood pressure, and your mental health. As you're adjusting to that diet and your body and mind seek to find their new equilibrium in this healthier place, navigating that period of time requires some skill and knowledge. And if you just plunge yourself onto a ketogenic diet, it could potentially be dangerous, and not because the diet is dangerous, but because the combination of the diet with certain medications and in the context of certain medical health conditions or mental health conditions can be very dangerous. So certainly do not stop medications abruptly, whether you're going to try this diet or not, because many psychiatric medications can cause dangerous withdrawal symptoms. So always get some advice and supervision.
So it's all very well us saying, do the diet, get advice from your health professional, presumes that there's a health professional out there with the knowledge to give you the advice, which is where I think your training comes in, why I think this is so important. So say a bit about that, because you are part of an international movement, not just in America, but I think worldwide, trying to give clinicians working in this space training. And it's not just training on the ketogenic diet, but also, and I think this is very difficult, is to establish DEprescribing pathways. I was involved with a number of others in writing a couple of papers on DEprescribing in metabolic syndrome. But in mental health, you've often got that going on and all the mental health drugs. So the DEprescribing pathways, and that, in the UK, pharmacists are employed a lot for DEprescribing. Most family doctors or GP surgeons in the UK now have their own in-house pharmacists, not dispensing medications, but managing the medication. And pharmacists are generally very good at DEprescribing. We're much more confident in it. But in the area of mental health, I'm sure not. And I'm very keen to encourage pharmacists to get involved and also to think about the DEprescribing pathways.
That is fascinating. I wish that were the case here in the United States. I don't think that happens here.
It's very rare. Yeah.
And so that would be wonderful, because most physicians are, again, sort of practicing in the dark and kind of trial and error. Oh, let's lower it by, let's make up a number in our head, X%, and see how it goes, right? So as a psychiatrist, having prescribed for 25 years, I did not learn this in medical school or in residency. You learn by doing, right? And you learn by making mistakes. I'm so sorry, patients that I worked with in my early years. I really didn't have a roadmap for DEprescribing medications. And so what I learned the hard way over years of experience is that everybody's different. So some people can come off medications more quickly than others. It might take person number one might take them, 4 weeks to come off 100 milligrams of sertraline. Person number two might take them a year. And so there's that piece of the puzzle. But the other piece is, is that, you have to, I think what makes the most sense is to go down by small increments and wait. You go down a little bit, you wait and see how it's going. You can always go back up if it feels like it's been too much of a drop, but go small, slow, patient, be patient, pay attention. You can and go back down by even smaller increments if necessary, and longer intervals. So it's really, really important to do it that way, because if you go too fast or use if your schedule is too fast or if your increments are too large, it'll be a really uncomfortable, terrible experience for the patient. And you'll get a lot of people thinking, oh, I can't come off this medication. It's not good for me to come off this medication. I need this medication. I think most people, that's their experience. And then they get the wrong impression that they need to stay on it.
For anyone who wants to look deeper into this, I watched a podcast, I think was with Metabolic Mind, when you were talking to Brett Scher. And there was a whole podcast with you discussing DEprescribing. So for anyone who wants to sort of look at that in a greater detail, I'd highly recommend that. I'd also highly recommend something called Bipolar Cast, because you were talking about Ian Campbell and Matt Bazzucchi, and they run this incredible podcast in which they talk about their experiences of bipolar, and they've interviewed everyone discussing, and from a medical perspective and from a lay perspective, and it shows, it's inspiring stuff. In your experience, in your clinical experience, again, this will be a huge range. So it's almost how long, I know before I ask the question, it's how long is a piece of string, but generally DEprescribing over what period of time, and what percentage of, if someone's on 5 or 6 drugs, can you get them off everything, or will they inevitably end up on lower doses of some? Or I know this is very individual, so it's in some senses a ridiculous question, but if you could give a kind of broad brush answer to it, to what's actually an unanswerable question.
Yeah, no, I think that, the answer to the question really depends on the degree of adherence to the diet. And so, because when people have good long-term adherence to the diet, they will often be able to reduce the number and or dosage of medications that they're taking. And in some cases, be able to come all the way off their medications. But even in people, and I really emphasize this in my training program, because even in people who are not able to make major changes to their medications on this diet, they will usually, in nearly every case, experience tremendous benefits from combining the diet with those medications. Because the medications, especially the ones that are causing a lot of metabolic problems, such as weight gain and high triglycerides and high blood sugar and so forth, when you add a ketogenic diet to, say, an antipsychotic, which is causing a lot of metabolic issues, what you see, and you see this in the studies, and you saw this in the study that I helped publish last year as well, and I see this in my patients every day, you see a lot of those side effects being counteracted by the diet. So, I have plenty of patients who have no interest in coming off their psychiatric medications, in certain cases because they've been life-changing or life-saving. They've kept them out of the hospital. They've kept them, in a job or in a marriage, what have you. And so they may have absolutely no interest in stopping a medication. The reason they're coming to me to get on a ketogenic diet is so that they can feel better and be healthier on their medications. Yeah. And that's one of the many magical effects of a ketogenic diet, is that it's really the best tool I'm aware of to counteract the metabolic side effects of these medications.
Brilliant. So there's a kind of all-encompassing theory about this, that whether you're talking about metabolic disease, mental health, autoimmune, there are some intrinsic links, and it's linked at the level of cell functioning and the way the body uses energy. And the fundamental processing of energy in the cell is done by the mitochondria. Now, when I was at university, we knew that we learnt about electron transport, and we knew that basically the mitochondria generate energy in the cell. And that's all we knew. Turns out mitochondria are fascinating, not least the history, which is, I think 4 billion years ago, a single-celled organism called an archaea swallowed a bacterium, and the two lived together happily ever after in splendid harmony. And from that, multicellular organisms were born. So there's a fascinating history. What's interesting about the mitochondria is they have their own DNA, and they're almost like a cell within a cell. And cells, as I understand it, some cells have a few hundred mitochondria, some have a few thousand mitochondria. And yes, they do generate from the energy of the cell, but they do far more than that. They actually run the cell, they organize the cell. Turns out they can merge and they can separate, and the latest evidence appears to be they can even move between cells. So if you kind of think how an entire multicellular organism is managed, and we think about, hormones and different functions, yes, that's true, but it turns out the mitochondria, well, I call them the mighty mitochondria. So we're not going to do a whole PhD thing on mitochondria here, but I don't know if you wanted to pick out a couple of areas that you find interesting, and then we'll move on.
Yeah, so mitochondria are fascinating. I talk a lot about them in the book. I really focus on their energy production capacity in my book because that's what I want people to focus on in terms of understanding on a, sort of on an accessible level, how they can impact their mitochondrial function with dietary changes. So, but yes, mitochondria are fascinating, ancient, mysterious, and really multi-talented. Tiny little sort of beings inside of all of our cells. And so I really do I focus on the energy production, and I spent an entire chapter really walking people through the difference between how your mitochondria function, how your mitochondria generate energy on a carbohydrate-based diet compared to a fat-based diet, so that people can see the differences, what some of the advantages are to switching to a fat-based diet. So you can see exactly how you're changing your brain chemistry when you follow a different way of eating. So if you feed your mitochondria a little differently, not only can you be more efficient in your energy production, but it's also a cleaner source of fuel to be burning more fat than carbohydrate, because if you're burning mostly glucose or for energy, if you're burning mostly carbohydrate for energy, then you're getting a lot more oxidative stress and a lot more inflammation, which is damaging to the mitochondria itself. And so to take better care of your mitochondria, you need to feed them a little more fat, a little less carbohydrate, and in many cases, it will be the right thing for you to do, depending on how much metabolic damage you've already sustained from eating the wrong way for too long, because we've all been told to eat the wrong way. Then you may even need to switch to a ketogenic diet, where really your primary source of fuel in your brain will gradually become ketones, more ketones, less glucose, and that will be a lot easier, a lot gentler on your brain chemistry, and you'll get this smooth, reliable, steady, drama-free source of energy 24/7, rather than being on this roller coaster of the refined carbohydrates going up, bringing your blood sugar and insulin levels and everything else up and down all day.
Yeah, absolutely. I always say if you've got a petrol car and you put diesel in the fuel tank, it doesn't end well. And I think that's what we're doing. I think we're fueling our bodies on the wrong fuel. And then our engines are misfiring, not burning the fuel very efficiently. It's damaging the engine and it's damaging the entire metabolism.
Exactly. Now try putting sugar in the gas tank and see how far you go.
Yeah.
I mean, it's a really, really good analogy. You can't expect your brain to function properly if you're not giving it the right fuel. And then you go to your doctor and expect them to fix it for you. And there's nothing wrong with the car. You have a beautiful Rolls Royce. You're just putting the wrong fuel in it. Yeah. So your mechanic can't help you. Only you can help you.
Yeah, I completely agree. And if your mitochondria are misfunctioning or misfiring, more and more damage is done to the mitochondria, and more damage is done to the surrounding cell. And then you've got inflammation, you've got the potential for cancer. It's not doing any good to your brain. And just to revisit an earlier slide when we were talking about insulin resistance. So in order for sugar to enter cells, it has to have an active transport mechanism. It can't just go in, it's actually sucked in by a special mechanism. And and this is something I learned from Stephen Kinane. It's sort of as your brain ages. I mean, I'm sure it's true generally, but so there isn't just one transport. There are these called GLUT transporters, and there are different transporters in different cells. I think 4 or possibly 5. I may be wrong about that. As you age, those transport mechanisms naturally start to fail. They decline. So you've already got a mechanism that as you get older doesn't work as well. If you've got insulin resistance overlaid on top of the natural aging process, you've got a double whammy going wrong. So now you've got damage on top of damage. So there are many ways to describe type 2 diabetes. It's conventionally known as the inability to handle sugar very well. But I always look about type 2 diabetes as effectively accelerated aging. Because we know that diabetes is, if you look at all-cause mortality, because that's the only thing I'm really interested in, you can obsess about your reduction in the risk of a heart attack or a stroke or cancer. But if you don't have a heart attack, but you die 2 weeks later of cancer, that's not a great benefit in my view. So I always focus on how can we reduce all-cause mortality. And a ketogenic diet, and keeping away from diabetes keeps you away from all these things, which explains this kind of link between, we know that if you're diabetic, you've got more likely to have bad mental health. And guess what? If you've got bad mental health, you're more likely to be diabetic. And all of this is associated with your poor old mitochondria struggling with the wrong fuel. Now, the science appears to show that very few cells rely solely on sugar for their energy source, but a small number do. And I may have this wrong, so correct me, Georgia. The red blood cells need sugar, and certain parts of the brain need sugar.
Yes. So I'm sorry. I'll let you finish.
Yeah. So if you've got these reduced GLUT transporters, don't allow the sugar to get into the cell as part of aging, and on top of that you've got insulin resistance, your brain's going to be deprived of energy, and parts of it will start to malfunction, either become hyporeactive and just not react, or become hyperreactive and overreact, or a mixture of the two. And that explains all these mixed up syndromes and often counterintuitive symptoms that we get. The same doesn't apply to ketones, as I understand it. So the ketones in your blood can enter the cells by a process of simple diffusion. In other words, they drift in. They don't need to be actively transported. And maybe that's part of the reason why I think the ketogenic diet is such a profound intervention. Is there anything I missed or got wrong in all of that?
Well, ketones do need a transporter. So it's called an MCT transporter. But that aside, what I would say, what is true, what is absolutely true, everything you said is very, very important. So glucose crosses into the brain. Really, no questions asked without it doesn't need any help from insulin. There is a glucose transporter on the surface of the blood-brain barrier that escorts glucose into the brain. But that transporter, unlike many other important cell types in the body, does not require insulin. So it's an insulin-independent glucose transporter that escorts glucose into the brain, and then there are insulin-independent glucose transporters inside the brain to help so that cells can absorb glucose, right? But the couple of interesting things here. So one is that insulin, it's so glucose, even if you get severe insulin resistance or type 2 diabetes, which is just an end stage form of insulin resistance, one of the many catastrophes that can happen to you if your insulin levels are running too high too often and you're eating the wrong way. You can develop type 2 diabetes if you're susceptible to that. But even if you don't get type 2 diabetes, something else will go wrong because high insulin levels, high glucose levels, and high insulin levels are damaging for every cell and organ in the body. So it's glucotoxicity. So if your glucose is a little bit too high, or especially, even if it's not all the time, every time your glucose is too high, you're doing damage to your cells. And this is why people with type 2 diabetes experience damage to every organ in the body. So high glucose levels are very, very toxic for the body as well as for the brain, which is part of the body. So whenever you're getting a glucose spike in your bloodstream, you're also getting a glucose spike in the brain because they mirror each other. So they're not the same, but they are proportional. So the higher your blood sugar, the higher your brain sugar. And every time you get a spike in your blood sugar, you will get a wave of inflammation and oxidative stress. And coming back to your premature aging comment, this is directly connected to premature brain aging, because when glucose levels go too high in the brain, which for most people in the world right now is happening after every meal, yep. Your brain sugar is also spiking, and that excess brain sugar literally sticks. It sticks to proteins and fats in your membranes, lipids, DNA molecules, all the important components of your cells. It will stick to those molecules and cripple them into these sticky, dysfunctional, caramelized clusters called advanced glycation end products, or AGEs.
Exactly. Beautiful mnemonic. Yeah. These
are what are responsible for premature brain aging and premature aging of the rest of the body as well. So like you're saying, it's a 1-2 punch. If you're experiencing these waves of glucose coming into the brain and they're very damaging to the brain, and then the cells can't, according to Professor Cunnane, if the cells aren't even able to get as much glucose as they need, so you've got damage from the glucose. Now you've got some failing glucose transport. Add on to that the insulin deficit. So the opposite happens in your bloodstream when it comes to insulin. The higher your blood insulin levels over time, the lower your brain insulin levels will be, because the more you bombard the surface of your brain, the blood-brain barrier, with excess insulin, you'll be doing damage to that insulin transport system, and the surface of the brain, the blood-brain barrier, will become gradually more and more insulin resistant, which means that insulin, even though glucose is still waltzing in, insulin is going to have a harder and harder time crossing into the brain. And that's a serious problem, because your brain cells cannot turn glucose into energy at full capacity properly without adequate insulin. So now you've got high brain glucose, low brain insulin. That's a 1-2 punch for the brain. And your brain can be swimming in a sea of glucose and still be slowly starving to death. And that that paves the path to Alzheimer's disease.
Yeah, certainly one of them. So we've covered quite a lot of ground. I thought it might be we've talked about the ketogenic diet and we've kind of touched on this. And clearly we haven't got time to talk about 16 different mechanisms of a keto diet, but I just thought you might want to pick out one or two that are particularly germane to the areas that we're discussing today.
Yeah, I think a few of them I'm really going to highlight, and I highlight in the book as well. One is that if you have insulin resistance of the brain, so you see, number one, there's alternative fuel to glucose, right? Yeah. So if you have insulin resistance of the brain, which now the more insulin resistant you are in the periphery and the rest of your body, the more insulin resistant you will also be in the brain. Yeah. And so what's going to happen there is you're going to have, again, too much glucose, plenty of glucose, not enough insulin to use it. That's what sets the stage for something called cerebral glucose hypometabolism, or sluggish brain glucose processing, meaning that you're not processing glucose at full capacity. Your brain is not operating on all 4 cylinders. And so what you need then is you need to bridge that energy gap. And ketones do this beautifully, because even if, and I think you alluded to this before, even if you have severe insulin resistance already, and you are having a lot of trouble getting insulin into the brain, and therefore you can't use glucose to its full capacity, ketones will still cross easily and beautifully into the brain And you will be able to burn those ketones for energy because ketones burn beautifully in a low insulin environment. So your ketone metabolism, transport and metabolism, will not be impaired, even at very late stages of insulin resistance. And so those ketones can come in and bridge that energy gap and bring whatever cells may still be sputtering, so struggling for life, back online. And I think that is when people experience this shift 2 or 3 weeks in, sometimes even just a few days in on a ketogenic diet, that's what they're noticing is my brain is waking up. I have mental clarity. I have mental stamina. I can focus. I can get things done. And so this is a really profound experience for people. And so, in addition to all these other, and when you're burning more ketones, as we said before, you get decreased production of reactive oxygen species. That's number 4. When you eat a ketogenic diet, you naturally have lower stable glucose levels. You reduced hyperglycemia. Therefore, you've got less inflammation and oxidative stress and less glucotoxicity going throughout the body. You're balancing your glutamate and GABA system, number 8. When you eat in a way that reduces inflammation and oxidative stress, which is fueling your body with a ketogenic diet, then glutamate, which is the brain's gas pedal, which is sort of the excitatory neurotransmitter, and GABA, which is the brain's brake pedal, your calming neurotransmitter, those will come more back into a better balance. So you will not be feeling so anxious and so hyperactive and so overwhelmed. Things will become maybe naturally calmer, more on an even keel. So lots and lots of other benefits here too. And these are all pretty much, I don't see, I think almost all of these are addressed in the book as well if people are, want to understand more about how these all work.
Yeah. So, you think about a ketogenic diet and it's just one thing. But actually, it's not one thing. It's our entire metabolism, our signaling pathways, the health of our mitochondria, the health of our cells, and by association, our entire body. And I must thank Amy Berger for that slide as well. Always important to credit other people's work and not steal it without borrowing it is fine, so long as you credit it.
That's great.
Okay, so I think we've somewhat covered this. I don't know if there's anything else that you want to add that we haven't covered in our previous discussions.
Yeah, I think the point of this slide is to help people understand that it's not just bipolar disorder and Alzheimer's disease, that we are now able to document evidence of insulin resistance and or sluggish brain glucose processing in all of the psychiatric conditions that you see on this slide. And so, if you improve your metabolic health by taking all that pressure off your insulin signaling system and taking your glucose levels down into a healthy range, bring your glucose and insulin levels down on a ketogenic diet, you could potentially impact all of these conditions, and potentially more because we haven't studied all of them yet. And so, the potential benefits are just limitless. And really what I tell my patients is, we don't know what's possible for you until we try. So why don't we try?
Absolutely.
Why don't we try and see? Yeah.
Yep. So this is kind of an illustration. We've talked about it, but there's some specifics here around the relationship between metabolic dysfunction and mental health.
These are very, very powerful associations. These are, anything greater than 2x should get your attention because anything greater than 2x suggests that there may be a cause and effect relationship going on there. You can't say for sure. But these are very strong associations. I mean, these conditions go hand in hand very often.
The other point for me is with the drugs industry. As you know, I'm famously the pharmacist that gave up drugs. You look at all the slides they produce, and they never talk about numbers needed to treat and numbers needed to harm. And they talk about benefits in terms of relative risk, not absolute benefit. I can't think of any drugs that have this kind of power right? So a drug might have a 20% benefit. And everyone say, that's game changing. There are no drugs that I'm aware of, and please correct me if you know of any, that produce 2, 3, even 4 times change. I mean, this is a scale difference in terms of efficacy.
And so there's another slide that you may want to put up with the effect sizes of a ketogenic diet compared to medications. So the study that I co-authored last year of Dr. Albert Danon's work in France, he used a ketogenic diet with 31 volunteers from his own practice. Some of these were people with treatment-resistant, so-called treatment-resistant serious mental illnesses, schizophrenia, bipolar disorder, and major depression. And he asked them to come into the hospital and try a ketogenic diet under his supervision to see if it might be helpful to them. And so what you saw on that bar graph was that the ketogenic diet worked 7 to 10 times better than medications do in clinical trials. So that's a huge effect size that you do not see effect sizes like this with medications. I mean, it's just, it just blows medications out of the water. So these were, every patient that stayed on the diet for 2 weeks or longer improved. And 44% of them achieved clinical remission. And it's just, and since we're talking about medications, you're a pharmacist, 64% of patients left the hospital on less medication, less psychiatric medication. You do not see that in conventional inpatient psychiatric care. People typically go into hospitals to get more medication. They leave the hospital on more medication than when they went in. So this is what we need to be doing. This is what we need to be studying. This is what we need to be offering people, whether they're taking medications already or not. I think this is a very safe, for most people, there are exceptions, very safe and really worthwhile intervention to make people aware of everywhere.
I think I first came across this paper because you tweeted it. Yeah. And so I went to the original paper and read it. And I couldn't believe it. I ended up reading the paper, I think, 3 or 4 times, because you just never, ever see results like this. So this wasn't a kind of group of mildly ill short-term patients. What Professor, I think he's a professor of medicine, Danon did, was he admitted his sickest patients that had been sick for 30 years. And they tried everything over many, many years. And they're a group of patients well known to him. And it wasn't just one group. Look on the left-hand side of the screen, bipolar, major depression, and schizophrenia, right? Pretty intractable diseases, right?
These were patients who were taking on average 5 psychiatric medications when they came into the hospital. These were patients who on average had already been in treatment with Dr. Danon for 10 years on average. So some patients as long as 30 years. Yeah. These were patients who had all been hospitalized before. Many of them in this very same hospital 1 or more times and had never gotten the results that they got when they added the ketogenic diet to the hospitalization. So this, I'm very glad it got your attention and that you had to go back and kind of read it. I'm like, wait, really? Yeah. Is this really true? Yeah. And this is what you see when you use ketogenic diets in psychiatric care. You see results that you have never seen before. And isn't that what we want? Absolutely. Isn't that what everybody wants?
Yeah. It's what we all came in to our professions to do. I mean, I got to a certain stage in my profession where we had a group of 10 pharmacists. They were nationally recognized. We won every award, some of them twice. I was very senior in the profession and I felt dissatisfied. Why was I dissatisfied? Well, in retrospect, I was spooning ever more tablets into people and they were just getting sicker more slowly. And we know that health professionals, by and large, are just as fat and sick and diabetic as everybody else, which kind of tells you something. And for me, this has been an absolute revelation in my own health. But my sense of professional satisfaction in doing, I mean, obviously, I'm not doing this kind of work, but at a much lower level. It's completely re-energized my whole professional career, this. I just wish I'd stumbled across it sooner, but it's what we all come into our profession, I think, to do.
I'm glad you said that, because this did reinvigorate my clinical practice. It's easy to burn out in psychiatry because everyone that's coming to you is in dire straits and not just needing, medical, sort of a psychiatric, in terms of medical evaluation, in terms of their medical history and what medications I can offer them and so forth, but they're needing emotional support. And so, and most of them are not getting better. And so when you're paying that kind of high quality emotional and intellectual attention to people, and your practice is, usually busting at the seams because the demand outstrips the supply of psychiatrists, you can burn out really quickly. But if you have an intervention that actually works for most people, that helps most people get better enough that they might not need to see you forever, that just is a game changer. And I think that's the way we need to be. I think this is really the future of good psychiatric care.
Is there anything you want to add relative to the Mediterranean diet?
Well, just that any of your listeners are thinking, well, the Mediterranean diet is a very high carbohydrate diet, and that's supposed to be good for the brain. How can both the Mediterranean diet and the ketogenic diet be good for the brain? Well, the truth is, they are both better for the brain, but which one, just because the Mediterranean diet is better for the brain, and it's been shown in 3 different randomized controlled trials now that the Mediterranean diet can be helpful in people with major depression. It hasn't been tested in epilepsy or any major mental illnesses, but it has been tested in major depression, and it can be helpful in major depression. But that's compared to the standard American diet, the so-called Western diet or standard American, whatever you want to call it. So of course it's better than that.
It could hardly be worse.
It's just about any change you make to the standard Western diet is going to be an improvement. Yeah. But not to disparage the Mediterranean diet, because if that's the only diet that you're willing to try, please try it, because it is better than the standard American diet. But there are many reasons to believe that it's not the best diet for the brain. And a couple of points to make here is that it doesn't. It's the foundation of the diet. Really, the biggest problem with the Mediterranean diet is the foundation of the Mediterranean diet is grains and legumes, and not just whole grains and whole legumes, but also refined grains, things like flour, pasta, bread, things like that. So this diet, unfortunately, pays no attention to metabolic health. So if you're someone who already has damaged carbohydrate metabolism, which again, most of us now do, this diet is going to be dangerous for your metabolic health. It will be too high in carbohydrate for you to safely metabolize. So I think that's the point that I think is most worth emphasizing.
Yeah. And the only thing I would add to that is, I think, like everything, the industry always hijacks anything for its own ends. And actually, sure, I think this is the kind of American Mediterranean diet, the American version of it. And actually, if you look at a true Mediterranean diet, it is much higher in fat and protein and much lower in. So, like everything, a Pizza Hut pizza ain't the same as an Italian pizza in a small town in Italy. So, yeah.
Of course, yes.
We've done a pretty good job of vilifying the pharma industry, but I wouldn't like to leave any stone unturned and just and not deal with the other villain of the piece, arguably the greater villain of the piece, and that's big food. And I bring this up because just look on this slide, and every brand you've ever heard of will be here. And these huge, I think it's 9 or 10 companies basically dominate the entire world's food supply. And they've got turnovers and profits bigger than entire countries. And where does their profit come from? It doesn't come from whole food. It comes from processed food. And it means that they've got literally unlimited marketing budgets to convince both the lay public and, let's face it, health professionals that black is white, that processed food is healthy, and it's all about a calorie controlled diet. I think this is an absolutely evil empire. And the more I get into this, the more I'm convinced of that.
I think that these are very powerful forces, and money is a very powerful motivator. And I think that regardless of what these companies are doing or why, at least in the United States, and I think it's not quite as bad in the UK. I forget the statistic with the UK, but in the United States, 60% of what we eat is no longer food. 60% of what Americans eat does not come from the land or the sea. It comes from a factory.
Yeah.
And we think of it as completely normal. And this is not food. And so, of course, we're not going to be healthy. Of course, our brains aren't going to function properly. Of course, our bodies are going to fall apart. What else would we expect? So regardless of what any of these companies decide to do, I'm not going to try to convince them to do anything differently. Individuals have to start taking responsibility for their own health. You have to, and I know this stuff is addictive, and I know it's cheap and it's convenient and it's everywhere. I get it. I know how hard it is to resist these things, but there is no other way out. You can't medicate your way out of this. You can't operate your way out of this. You can't legislate your way out of this. You have to take responsibility, and you've got to find a way to eat real food. And if that's all you do, because it's a big change, maybe you won't even need to do a ketogenic diet.
Yeah.
Especially if you're young and still healthy.
Yeah.
You may just eating whole foods, sort of more of a paleo style pattern, which is one of the patterns I recommend in the book. My book has more than one recommendation because I know keto's not for everybody. So there's different places for people to grab on and get healthier. That may be all you need to do. So you just have to learn what the rules are, the actual truth about the science of nutrition and health is not what you've been led to believe. So if you have the right information, there's a lot you can do to feel better very, very quickly.
We were both at the Swiss Re conference a few months ago.
Yeah.
And Georgia did a fantastic presentation, which is online now, so do look at that. And it's a collaboration between Swiss Re and the BMJ, British Medical Journal. And it's all available online now for free, including Georgia's presentation, but much else besides. Insurance companies are starting to realize that diabetes and all the consequences are not inevitable, and realize that they're picking up the tab. And if people eat healthy food, they can reduce their prices to the consumer while at the same time making more profit. If a reinsurance company can realize that, I just wonder why none of our health systems seem to be able to. So I'm trying to work with in the background with some of the UK politicians to get them to change their whole approach. Because we pick up the tab either way. Either we subsidise real food and education for people who can't afford it, or we can tend them to eat a lifetime of this food, and then we pick up the bill through the pharmaceutical company 20, 30, 40, 50 years on. I know which I think is the better path. And the money gets spent either way. Actually, I reckon it'd save a lot. So yeah, the marketing, and there's been lots in the BMJ actually. I think they've done a very good job of showing how big food has polluted food research. I mean, Coca-Cola alone has spent billions, and Kellogg's and all these companies have spent billions of pounds convincing us that black is white. In some senses, we've covered this in our discussion around Danon's work, but do you want to say anything more about the relationship between insulin resistance and bipolar?
Yes. We were talking about these strong associations between poor metabolic health and poor mental health, and insulin resistance in particular. And so associations, not causation, but these associations were so strong to suggest that there might be, this might be more than a coincidence, that insulin resistance may be more than just an innocent bystander in mental health conditions. And so we're starting to see evidence come out from rigorous clinical trials, helping us to understand that insulin resistance is not just an innocent bystander. It is playing a direct role in the severity, at least of bipolar depression, We already know that it's playing a direct role in Alzheimer's. That's been known for a long time. But it's playing a direct role in the severity of bipolar depression. So when you look at this study, what Dr. Cynthia Kalkin did of Dalhousie University, she's a bipolar specialist, psychiatrist, and researcher, and she took patients with treatment-resistant bipolar disorder and gave them a medication called metformin, a generic medication that improves or has the potential to improve insulin resistance. And in every patient where insulin resistance was reversed with this medication, they saw a dramatic reduction in their depression symptoms, every single case. So if you have insulin resistance and you have bipolar depression and you reverse that insulin resistance with the medication, your depression gets better. So that is a beautiful study. And if you can do this with medication, one imagines you could also do this with a diet that improves insulin.
You think?
Yeah, I think so. This, I think, is a really, really important study. So I'm glad that you put that up.
I just want to add a couple of things. One is metformin is a fascinating drug. It's the only anti-diabetic. I talked about all-cause mortality, and it's the only anti-diabetic agent that's been shown to improve all-cause mortality. And some people are investigating it as a life extender of its own. And when we talk about drugs, we often talk about pleiotropic actions. And pleiotropic means manifold different actions. And what's fascinating about metformin is, guess where it works? On the mitochondria.
Yes.
And it also explains interesting. So commonly used for polycystic ovarian syndrome, why would you treat a female who's unable to get pregnant with an anti-diabetic drug called metformin? It just all links together so beautifully.
Doesn't it?
Yeah.
They might all have something in common, these conditions.
Absolutely. And I think we're proving this in almost in three-dimensional ways now.
Yeah, and so as you can see on this slide, same researcher, Dr. Kalkin, she found that if people with bipolar disorder who also had insulin resistance or type 2 diabetes, which is an end-stage form of insulin resistance, that they were more likely to have rapid cycling mood patterns. They were more likely to have chronic symptoms, deteriorating disease course, and they were less likely to respond to lithium, the mood stabilizing drug lithium. So, and again, we are seeing, this is another clue that insulin resistance is playing a direct role in if not the development of bipolar depression, at least the severity and course of that depression.
Okay, so we've talked about effect size, we've talked about that. And I think this is really important because this is part of the conclusion of your book, that everyone deserves a metabolic evaluation. So let's say a bit more about that, because I think this is of fundamental importance. You need to know where your metabolism is, and you need the tools to evaluate it. And then you need to know what to do about it. But if you've got no data as a starting point, you don't know how to measure it, you're a bit in the dark, which is what most people are.
It's true, because the top two labs there, the fasting glucose and the hemoglobin A1C, everybody knows their fasting glucose and hemoglobin A1C because that's what gets measured.
Yeah.
Those are, that's, after the horse has already left the barn, that's when those are going up, right? So your fasting glucose and hemoglobin A1C will only be abnormal once you have type 2 diabetes, which takes up to 20 years to develop. Wouldn't you rather know if you are on the road to type 2 diabetes so you can turn around? And so the measures on the second part of this slide, many of these you can do yourself at home, or you've already had these tests. You can look them up in your records. These are the tests you want. These are the tests that will give you insight into whether you have insulin resistance, often called pre-diabetes. That's what you really want to know. So, because you can turn these numbers around very quickly.
Yep.
It's unbelievable how quickly you can change these numbers in a matter of weeks. And so, you want your fasting insulin to be in the single digits. You want your waist to be less than half your height. You want your triglycerides below 1.1 millimole, because we're in UK, we use that unit. Yep. And divide your triglycerides and your HDL and take a look at that number, make sure that's in a healthy spot. And so these are really powerful tools for people because they will tell you where you stand on the insulin resistance spectrum. And once once you see that there's insulin resistance going on, which most people will, then that empowers you. Because you say, you know what, you can do something about this. You don't have to just wait until you get type 2 diabetes.
Yeah, completely agree. Sadly, in the UK, some of these key tests are not tests that family physicians can order. So the fasting glucose to hemoglobin A1C is fine, but they don't get to order insulin. So they can't. HOMA IR is the relationship between sugar and insulin. So they can't do that. There are ways of extrapolating it. So there are some backdoor ways to kind of access this information, even with the standard set of GP tests. So if anyone wants some advice on that, do contact me. Or if you want to have these panels done, when I do my standard panels, we include all of these and more. So I think George just explained why these are just so important. Okay, so we're coming to a close, and I've really appreciated your time, Georgia. So you're creating this. We talked earlier on about the training you're providing, but also you're creating a international clinician directory, so people know where to go for help.
Yes, because we need more access to these services. We need more clinicians trained in using these services. So that's why I created this training program several years ago. The training program. So I created this directory so people can find clinicians who already use these, offer these, ketogenic diets in their practice specifically for mental health conditions, not just for losing weight or improving, your blood sugar levels, but specifically for mental health. So if you are provider listening to this and you use these strategies in your practice, it's free to submit your listing and list yourself on this directory. We're trying to grow this directory as much as we possibly can. And it's free to search the directory. It's completely free, public service. Please use it and help us grow it. And you can also find collaborators and other people to build a team if that, or do research if that's your preference. So I hope that this will be useful to people.
I think it just shows what a pioneer you are and what a visionary you are, Georgia, to take these things forward and to be so generous in the way that you're doing it, rather than, clutching these things tightly to your chest and trying to own it. So, and broadly, that's what I found about the low carb keto community. People are very open in their culture, non-hierarchical, supportive and non-judgmental. And that's one of the reasons I've just so much loved being part of the community now. I was lucky to be sent an advanced copy of your new book, which is coming out. I'm still waiting for my Amazon delivery, but I think it's coming out towards the end of the month. And it's a fantastic resource. Talks you through in much greater detail, obviously, than we've been able to today. This kind of journey, how your diet affects your mind. It's quite accessible. There's plenty of science in there, but I think it's quite accessible for the layperson as well. So you don't necessarily need to understand all the science to get a lot of the benefits. There's a ton of resources in there. There's places to go. There's recommendations. There's even a series of dietary interventions. Can't wait to get the actual hard copy in my hands for this, Georgia. So tell us, is there anything in the book that we haven't got to go through the book specifically, but anything in the book that we haven't covered that you should want to pull out for people to encourage them to consider it?
No, I think we've touched on a lot of the main themes in the book. The root causes of our mental health crisis are largely metabolic, that, the ultra processed foods are toxic, that high glucose levels are bad for us, that high insulin levels are bad for us. We haven't talked much about the plant versus animal question, but there's a whole chapter in the brain about the risks and benefits of plant-based diets and what the science actually says, and how, and I think, and as you said, there are dietary strategies at the final portion of the book to really walk people through if they'd like to try to improve their mental health with diet. But there's a whole section of the book. The third section of the book is all about food. And it's actually one of my favorite sections because I'm really fascinated by food. And so every food group, the grains and the beans and the nuts and the seeds and the, meat and eggs and dairy and fruits and vegetables, each one has their own chapter dedicated to them so that you can understand the real risks and benefits of these different food groups and understand how they operate and how they think. I'm sometimes I think of myself as a food psychoanalyst. I like to know how food views the world. Because if you actually look at food from food's point of view, everything makes perfect sense. Then you understand what's actually good for you and what's not good for you. So hopefully that'll be interesting to people as well. But anyway, thank you very much for reading the book and for inviting me on and talking about these really important topics. And I really appreciate how much time and attention you put into these different themes that are so important in the connection between mental health and nutrition, metabolic health. So it's been a really, really great conversation.
Georgia, as ever, it's been a pleasure to catch up with you. The book is fantastic. As I say, I think my copy is about 10 days away somewhere in an Amazon warehouse. I'm looking forward to it. Highly recommend it. Can I pay tribute to your just general loveliness, Georgia? It's just such a pleasure knowing you and, being in such a warm, supportive community. Medicine can be pretty hierarchical and pretty arrogant. And we've all experienced that. And this community is nothing like that. Very empowering, very enabling, and that's how we should be. So, I wish you every success. I wish the book every success, and hopefully we can keep in touch in time and see how. I'm waiting for your next publication and see what comes next.
Well, thank you for your warmth and generosity of spirit, and for breaking the mold when it comes to pharmacists. So it's wonderful what you're doing, and thanks again for all your time.
Pleasure. All the best.
You too. Thank you.
If you enjoyed the podcast and want to find out more, join our Wellness and ProLongevity Facebook group. Don't forget to subscribe and follow so you never miss an episode, and maybe share to friends and family who might benefit. Finally, if you think you might need help with diabetes, heart disease, or any of the other diseases we discuss, then book a free consultation with Graham. There's absolutely no charge for this, and we would never put you under any pressure. What do you have to lose? Bye for now, and see you for the next episode.